share the screen for the didactic.
Okay. Thank you.
Okay. Can you hear me?
Yes.
Okay, well, let me. Okay, I think okay. You have the presentation pulled up, right?
Right. So Janet will advance your slides. Dr. Mara, if you'll just tell her when you're ready.
Okay, great. Next slide, please. Thank you. And next slide. Okay, so we had the presentation a couple of weeks ago, maybe a month ago, on diabetes and hepatitis C, and we kind of touched a little bit about fatty liver. And the goal today is to give you some guidance on how to work up a patient with fatty liver. So there's 15 slides. I may skip one or two for time reasons, but I wanted you to have the whole set for your review in case you need it. So we'll start with recognizing NAFLD. So NAFLD is the acronym for non-alcoholic fatty liver disease, and it's defined when you have more than 5% of your hepatocytes with steatosis by either a biopsy or by magnetic resonance. It is very important that before you label a patient with NAFLD, you rule out secondary causes of fat accumulation in the liver. For the best example is alcoholic fatty liver. So once you have the NAFLD diagnosis, the only way to differentiate from NAFLD from non-alcoholic steatohepatitis is through a liver biopsy. But having said that, you don't really always need one for treatment decisions, and I'll explain why a little bit later. Now, the importance of the deciphering if it's NAFL or NASH, it's because the one that really requires treatment is NASH, because that is a driver for cirrhosis and liver cancer. And there is some controversies if NAFL can do it before you get into NASH, but I won't go into that right now. Next. Okay, so it is a very prevalent disease, and I will go through this slide pretty briefly. And the reason is because in our country, we have a lot of people who are overweight, and we have a lot of people who have diabetes. And NAFLD is very associated, very closely associated with diabetes. And it is one of the, it will become in the United States probably the #1 cause of liver transplantation if it's not there already. The first cause until recently was hepatitis C, but with the advent of all these antiviral therapies that you guys are using very well, people who with hep C don't progress to cirrhosis and don't need a liver transplant. Now, the important thing is, on the last bullet, is that the most important prognostic indicator in NAFLD is the presence of liver fibrosis. And you guys are already pretty savvy in identifying liver fibrosis. And if you identify that the patient has an advanced stage of fibrosis, you can proceed with the treatments without actually requiring a liver biopsy. Next slide, please. So this is just to visualize from how do you go from a normal liver, then you start accumulating fat in your liver, then there's that fat causes inflammation in your liver, and if left in place, you end up with liver fibrosis, severe liver fibrosis, and cirrhosis. And next. So just to put things into perspective, if you have 100 patients with NAFLD, in 20 years, 5 of those 100 without treatment or interventions will develop liver cirrhosis. And of those who develop cirrhosis, in 5 or 10 years, 2 or 3 of those 5 will decompensate, and 1 or 2 will either die or from liver-related death or will require a liver transplant. So when you look at the numbers, you say, well, it's only 1 or 2 out of 100. The problem is that NAFLD is so prevalent that even when the poor outcomes are only 1 or 2 patients out of 100, it really does have an impact on your health system and on your population. The best example I can associate with this is COVID. COVID kills 1 or 2% of the people. It doesn't seem too much, but you've all experienced what this has done to our, in the United States. Next slide, please. I'll skip this one for now. Next slide. Okay, so what are the main drivers for NAFLD? And you have the list there. It's obesity, dyslipidemia, type 2 diabetes, metabolic syndrome, and polycystic ovary syndrome. So in general, because of the frequency, obesity is the main cause in the United States. But when you look at populations, it's probably more prevalent in a diabetic population than an obese population without diabetes. But we have much more obesity than diabetes, and that's why obesity ends up being the main driver. Next. Next slide, please. Okay, so the clinical presentation, let's go back one. Nobody presents to your clinic saying, I have symptoms of fatty liver. It's usually an incidental finding because you did an ultrasound of the liver or the abdomen for whatever reason, and you found that the patient had fatty liver, or because they had elevated liver enzymes, and you started them working the patient up, and they ended up having fatty liver. And now there are some recommendations that you should be screening patients with diabetes for fatty liver. So many times it's just, I would say it's an incidental finding, but now that we have more information, we probably in the future will have some screening interventions on a group of patients that have high risk for fatty liver to identify it. Next. So for practical purposes, the most common and useful tool to diagnose or establish the first diagnosis of an NAFLD is an ultrasound. Now, it won't capture 100% of them, but it will capture the majority. And it is and something that is easily to do. It's not very expensive compared to MRI-based techniques. Now, if you have a FibroScan that has a controlled, that has CAP, which is controlled attenuation parameters, that's just an extra software on the machine. You can measure the fat on that patient's liver, but you really don't need that. An ultrasound, should be enough for the majority of patients. But as I mentioned previously, you need to rule out other causes of fat in the liver, like alcohol. Sometimes we've seen a lot on hepatitis C, especially genotype 3s, medications, malnutrition, and you have a list of hereditary disorders there that are associated with fatty liver. So when you run into a patient with fatty liver, first rule out all those causes. I would say the main cause is alcohol. And sometimes viral hepatitis and medications. Next. Okay, so this is the juicy part that you have been waiting for. So you identify a patient who has a liver ultrasound that shows fatty liver. So the most important thing is to stage their liver fibrosis. Now, there's several calculators out there, and I will mention the two most frequently used. The first one, it's a NAFLD calculator, which is the one on the left, and it uses several parameters which are listed there, like the age of the patient, the AST, the platelet count. I can't see very well because of the colors of this, the BMI, the albumin, etc. And it gives you a number. And if the number is on the left-hand side greater than 0.676, the patient's at high risk for having advanced liver fibrosis due to NAFLD. And if the score is less than negative 1.455, the patient doesn't have liver fibrosis. You use that calculator, and you can download it in your phone. And the other one is the FIB-4 score that you are very familiar with. The only difference is the cutoff points are different. You can see on the right-hand side that it's less than 1.3, and for Hep C, we use 1.45. And more than 2.6, and for Hep C we use 3.25, I believe. So the cutoffs are a little bit different, but the measurement, the interpretation is similar once you meet those cutoff points. So if you have those two tests that give you a low cutoff, it's very rare that this patient will have advanced liver fibrosis, and you just need to follow that patient once a year. But if the patient has both calculators that give you a high score, then that patient has high risk of having advanced liver fibrosis, and you would consider them for treatment. And if you want to be more precise, you could consider a liver biopsy, but it's not really needed. And then you have the indeterminate patients like we do with hepatitis C. Next. And for those, you can use a FibroScan and look at the scores and help you separate those indeterminate patients from put them on, one end like low fibrosis or the other end high fibrosis. And if you don't have a FibroScan, maybe you have an access to an MRI, and you can talk to the radiologist to see if they have the software to measure this. And if not, a liver biopsy would also be an option to do this. Next. So I'm not going to take a big dive on treatment today, but the most important factor here is weight loss. And you can see on this scale that if you achieve on the left-hand side more than 10% of your weight loss, you can cause regression of fibrosis on that liver. Now, how many people can maintain that more than 10% of weight loss? Look on the right-hand side, it's less than 10% of the people after a year. So, but when you go down that scale, even if your patient loses 5% of their weight, that still decreases improves the inflammation on that liver, and 30% of the patients can maintain that weight loss. So weight loss is the next slide, please. It's the main intervention. And although we'll leave treatment for a different talk, just have in mind that for patients who are diabetic, pioglitazone has been none of these drugs are FDA recommended, but there's good data that pioglitazone can decrease liver fibrosis in patients with diabetes and NASH. And also for patients who are not diabetic, vitamin E at 800 units per day, there's a good evidence that it can improve the liver histology. So in summary, okay, this is a summary. Let's just stop here because this is a summary of both talks combined. The previous one I gave a couple of weeks ago and the other one and this one. So I'm open for questions. I have 1 minute. I have to leave.
Dr. Mira, I don't see any questions in the chat. That was a really good presentation. If any questions come up after you leave, then I'll relay those to you via email, okay?
Okay, sounds good. Thank you so much.